my first question is that Rajiv had been here and Rajiv had been in outside India,
Dubai and UK.
in Dubai and UK, and recently there has been a controversy that doctors are bad. One of the film hero, one of the star hero of our country, said that doctors are bad. He never said this doctor is bad. He said doctors are bad. So my first question is very clear, very simple. That how do you find each one of you the interventional procedures, whether they are done in India or in Dubai or in UK or in US, in the best of the centers, in the hand of the best of the trained people, are they same or there is difference? I start with Rajiv.
Well, I think, KK, you have touched a very, very sensitive subject, and the issue, the episode I watched, and this was an instant reaction, and anybody who is not aware or who is not a physician, obviously will get biased with the opinion which was given. If one person has done something wrong, it cannot be generalized to everybody as a bad profession. That was one thing, and second is that it is also reflecting badly on all of practitioners who are working faithfully, lawfully, taking care of the patients without any bias, keeping their income package separate to the interest of the patient. And most of the physicians, they do take care of the patient. We have taken an Hippocratic oath, and we continue that.
Dr. Rajiv says that the treatments in most of the places, if treatment is done by good doctors, it is same whether you do it in India or anywhere else. Do you agree?
No, I agree with that. And to answer your first question more specifically, I don't think doctors are bad. I think there are some bad doctors, just as there are bad engineers and there are bad attorneys. I think the consequences of being a bad doctor is more emotional than some of those other professions, and that's why it receives so much press or so much notoriety when one doctor or a single person does something that's wrong.
Dr. Buckley, what will be the percentage of bad doctors across the globe?
Oh, yeah, I think very, very small. I was head of the physician review committee for a major hospital in San Antonio, Texas for about 4 years. And, about less than 1% of the total number of physicians practicing caused 95% of the issues. And there are very, very few that really are not very altruistic and very dedicated to taking care of their patients. The other thing is, one of the perceptions that gets medicine into trouble is there's a difference between being a bad doctor and having a complication to a procedure that you do. Unfortunately, the public wants a perfect result every time. They do. Now, so do I. I mean, if I'm a patient, I want a perfect result. But unfortunately, there are complications with every procedure that we do. And in a small number of cases, patients sustain those complications, which really are not the fault of the surgeon or the cardiologist or the physician who's taking care of them. Most of the time, we don't have control over what the patient does to themselves before we get to take care of them. Most of them smoke. Many of them abuse their bodies in other ways with drugs or with alcohol. And in our country, it's not uncommon to have people with drugs and alcohol, which tend to increase their risk of any procedure or any intervention that you do. And many of the times you don't know that they have these issues beforehand because you see them as emergencies.
So error is human.
It is, correct.
That's what it is. 98,000 people die every year in US alone. This is 1997 figure, and which turns out to be that 4% of the people who enter a hospital ends up with some complications. So medical accident, medical adverse event is not medical negligence.
I think that's true.
So in terms of vascular surgery,
Yes.
what is the risk of adverse events and people dying because of the procedure?
Well, I think it depends on what the procedure is.
In total, if I talk about the whole, if I do 100 vascular interventions, what will be the risk involved? And what will happen with that is people will start taking that as medical negligence when it is not.
Well, somewhere around 5 or 6%.
5 or
I think across
6%.
the board would be an acceptable complication rate. You look at carotid endarterectomy, it should be somewhere around 1 to 3%. If you look at carotid stenting, stroke related, that ought to be somewhere between 2 and 4%, something like that, in the hands of an experienced operator. If you look at somebody getting managed for an aortic aneurysm, you're getting an endograft, probably less than 1% mortality. If you're getting an open operation, probably around 3 to 4%. Depends on the other things that are wrong with the patient. So I think that across the board, you look at all the procedures that are done, probably somewhere around a 4 to 5% complication rate or a mortality, not necessarily a complication rate, a mortality, is probably not unreasonable. I think it's not unreasonable.
Dr. Das, you want to add something?
I think I'll have got a different perspective because I'm fortunate to be trained in India as well as in UK as well as in USA, and currently I'm practicing in United Kingdom. And we have developed a different kind of philosophy of care, which is almost kind of similar to what United States is doing. But what we are looking at, that what kind of quality of service that we are providing to our patients, whether it is intervention or non-intervention. Like for example, in United Kingdom, we have got a audit program or survey program called PROM, Patient Reported Outcome Measures. They want to know what the patient feels that any particular intervention has been done for them. Has that improved the quality of life for them? Is it justified that they should be spending so much of money, or should we be harming them or doing any good to them by doing this procedure? That's one part of the story. The second part of the story, what I think, probably there is some truth in it in somewhere, that there are some good doctors, there are some bad doctors. But what we need at the end of the day, we need a fantastic amount of good work, that any intervention that is being done, audited, and put to some scrutiny, that yes, somebody's practice is being looked at and this is delivering the right care.
Do you agree with the statement, bad doctors in good system and good doctors in bad system?
I think you can't generalize like
generalize.
that.
No, I don't think you
think
can.
so.
I would say you could not generalize.
You can generalize.
No, because
Okay.
I've
Now,
seen some really,
in India is the hub of coronary artery disease. We have the maximum number of heart patients in the world. And we know that it is linked with erectile dysfunction. We know it is related to impotence. So there will be maximum number of erectile dysfunction patients in India. What the vascular surgeon has to offer today for Viagra failure patients? Is there something which interventional cardiology will offer?
I think it's still under investigation. Clearly, there's a link between having coronary artery disease or atherosclerotic disease and having erectile dysfunction. The problem is that it's not well established that correcting or revascularizing is the only thing that needs to be done for those patients.
Will pudendal artery revascularization work?
It works, but it only works for some patients. Impotence is not just a sort of a hydraulic issue. There are a lot of other components to it.
one of the major components is the failure of the autonomic nervous system, which occurs in people who have diabetes, either overt or latent diabetes. And it also is seen in some people that have, really severe spinal stenosis or degenerative disease of in the region of the cauda equina. And so they get autonomic nervous system dysfunction, which causes them to have the equivalent of erectile dysfunction. They may get an erection, but it doesn't last. They are unable to sustain the erection because they've lost their venous sphincters, and so they deflate rapidly. And that is probably one of the more common causes, even in our country, of erectile dysfunction.
I think venous leak.
Venous leak is probably
more common.
the most common cause. And I'm not an expert in this area, but I know enough about it to say that with some degree of certainty that is probably the biggest cause. Viagra helps that some because it does it works to maintain engorgement. But if you have a significant leak, it won't work for you at all. You know, the people who benefit most from Viagra are the people who don't need it.
And then
So
there's one small trial that used stenting for
Yeah, hypogastric artery.
hypogastric and pudendal artery stenoses, and the results were
Plus minus.
Yeah,
results
yeah, they
were
were-
One more.
not
Some other issue I want to pick it up is that when we have a chronic limb ischemia and somebody says amputate the limb, what do new we have to offer? Is there any role of autologous stem cell transplant, bone marrow stem cell transplant?
Oh, I think that's a Pandora's box. I mean, I think when somebody shows up with a chronically ischemic limb, one hand needs to go through all of the drill of evaluating them physiologically, you know, some form of imaging study to look at their vessels, and then decide if there is or is not some means of intervention. And that is tied to really what their longevity is. I mean, you know, people with chronic limb ischemia, with critical limb ischemia, that have had chronic limbs show up with, usually there's something that brings them into the hospital or into your office. About half of those people are dead in 2 years of other issues. Somebody mentioned this morning, 25% are dead in a year. About in our country, the statistic is about 50% are dead in 2 years, which makes it very difficult for us to even gain any valid information about the durability of some of the interventions that are done, the endovascular interventions, because the people die of other coexisting comorbidities. So you can't really get a long-term follow-up on the effectiveness of your therapy. That plus the fact that the therapy devices are changing so rapidly that you start out a trial with one, and by the time you're halfway through it, you're in the third iteration or third generation of that device, and that also influences outcomes. So that's a very difficult question. I will say that there are a few patients who really are benefited with a primary amputation rather than a long drawn-out trial of intervention and bypass and everything else. I make every effort I can to save a leg, but there's some conditions that I know that no matter how good I am and how thorough I work and get my work done, the outcome is not going to be positive for that patient because of the nature of their disease. There's somebody that's doing, Joe Mills in Tucson has done some work about this, and there have been some other people in Europe, and actually, I think even in China, people are beginning to look at this thing called the angiosome, which is actually the area of the limb which is perfused by an end organ vessel. And actually there's a way of looking at that with indocyanine green and some other things in geography, which honestly gives you a much better idea of whether if you revascularize this, is it actually going to help heal the problem on the patient's foot or toe. And I think this is a very unexplored area right now, but there are people in Europe, in the United States, who are really looking at this again, and we've started to look at it. Our group has started to look at it. And actually Dr. Dietrich, who's here, had Joe Mills speak at his program and someone else in February to this issue, because I think it's an important one. And I think that may provide some guidance as to whether a patient really will benefit from revascularization or not, and if they do, what should be revascularized? Because you've seen, like I have, where we've done an excellent bypass, get a great dorsalis pedis pulse, and the heel ulcer never heals, and they end up having the leg cut off because of sepsis with a functioning bypass, which is terrible.
I think I quite agree with you. I mean, to answer your question about the bone marrow transplant, I think there is a group in India itself. They presented their findings or their study results at the Charing Cross Vascular Symposium. And they actually raised our expectation that it is the way forward. That's
And it may be.
It may be.
Yeah.
And besides that, there are some lot of experimental work that is being done, like say, the gene transfer injected into the calf muscle, but they have fallen apart. That didn't work. And there are also the omental transplants. We did some of the work, particularly for the diabetic foot. But again, it is a very labor-intensive procedure, and the outcome edge says that.
I will just put an input because I am showing a case for critical limb ischemia, and this was a patient who has got a dorsalis pedis, peroneal, and posterior tibial. They all were 99% blocked and long disease, which is lasting for about 10 centimeters, and it was all diseased, thoroughly diseased. I'm going to say non-healing ulcer, diabetic, hypertensive. He had a bypass before, and end up with me because I was doing some peripheral work, and they said, look, we can always only vascularize. We can't predict because the surgeon said that there's nothing can be done. You need amputation. I said, look, that's the last thing one should do, and we'll try a vascularization. If it does work, that's you're lucky, because every case respond in peripheral arterial disease differently, and depending on what is the background you have. And we did a multiple drug-eluting coronary stents. I put in and about 6 coronary stents, and he improved. His non-healing ulcer improved drastically. As a similar patient who had more than a year now, he can take his dog for a walk for a kilometer, who could hardly walk 100 meters. So I think it varies from a different patient to patient, and as Professor is saying, that it has to be, cannot be generalized. It has to be tailored.
Very individualized.
One more question before we ask some basic points. Leech in India, what do we call them as internationally? Leech?
Leech, yes.
Leech.
This is a therapy.
Is a therapy used in India for 5,000 years.
Yes.
And a couple of years back, US declared that this is now a medical device, and it is being used for venous stasis and venous ulcers. Any experience?
It's also used. The experience I've had is use it with flaps, where you do a transplant,
skin flaps for the knee arthritis,
where you're doing microvascular anastomoses, and you've only got 1 or 2 veins, and that's not enough to handle the vascular load. The leeches will decompress it until they'll get enough collateral. It's usually the problem of reactive hyperemia when you revascularize it, that it swells, and the swelling compromises the venous outflow. So if you can get the leech to help relieve the venous congestion during that hyperemic phase, the flap will probably get by. So they are used. They're still used in the United States.
Okay. So what I'm going to do is I'm going to ask each one of you that give me 5 sentences for a general public, what they should know about endovascular intervention and surgery, and the same thing for a family physician. So same sentence, which can be used either by a family physician or by a general public, what they should know about endovascular interventions. So each one of you give me 5, so that I have 25 statements.
Number 1, endovascular therapy.
Anything related to vascular, it can be prevention, it can be surgery, it can be intervention, it can be risk factors, it can be early diagnosis. It doesn't have to be advanced, something very basic. You can focus on prevention.
So something basic. Endovascular therapy may be an alternative to surgical therapy.
That's one. So alternative to surgery.
And number 2 would be endovascular therapy is complementary to surgical therapy.
So it can be either alternative or complementary.
Number 3 is stop smoking.
Stop smoking, absolutely. Smoking and vascular disease are together.
How many is that? That's 3.
4.
Number 4 is this be more for the general practitioners, for patients that have coronary artery disease.
Look for
There's a high likelihood that they have peripheral vascular disease.
Any percentage?
Probably over 30%.
30%. So 30% of patients with coronary artery disease will also have a vascular disease as well. 5th.
And 5th is keep your blood pressure under control.
So keep your blood pressure under control. Okay.
I think we'll
6th.
I was going to say that's why I'm glad I went first. I struggled going first.
I think importantly, the risk factor modification is critically important for all people with vascular disease, and that means statin therapy if it can be afforded, and some form of antiplatelet therapy in the form of aspirin. I think that if I had my way, I'd put statins and aspirin in the drinking water so that everybody got them.
So you are advocating a polypill therapy, and you are advocating that statins and aspirin should be given to everybody.
I think it's very important.
And there has been a recent study which talks about that aspirin should not be given to everybody.
Well,
only yesterday it came in one of the conference. So statin, aspirin.
Right.
2. 3rd.
I believe also that the endovascular repair for abdominal aortic aneurysm has been one of the major improvements in vascular surgery care in the last 2 decades.
Okay, so in
Without
aortic
question.
aneurysm
The endovascular repair.
endovascular repair.
Right, changed it from a big operation to an overnight stay or 2-day stay in the hospital. And it's a huge, even if you look at the number of people who have some complication to the device, which are very small, even that number of people, excluding, even taking those into consideration, the benefit to the patient has been huge in terms of ability to get back to their a good quality of life, which is, I think, important.
3, 4.
I think my own personal bias is that cerebrovascular occlusive disease needs a good trial of current intensive medical management rather than an intervention if people are
Optimal medical treatment?
if people are asymptomatic.
It's something like chronic
We
stable
call it
angina.
BNT,
Right.
yeah.
No, I'm talking about cerebrovascular disease. I think if you know that someone has occlusive disease and they're asymptomatic, I think optimal medical management should be your first line of therapy rather than an intervention in most circumstances.
Last 4.
What's intervention now?
Well, any intervention, either one, either intervention, yeah. The last I would say is that I'll second his judgment about the treatment of hypertension, because hypertension, poorly treated, is responsible not only for coronary artery disease, but probably one of the largest causes of renal failure. And
How low is low?
Need for dialysis. Well, the guidelines used to be 140 over 80. It's now down to
120.
about 120 over 80. Yeah, and I would say that you certainly somewhere between 120 and 140 over 80 would be optimal.
Raju, fair points.
I think intravascular area has vastly developed. It has expanded it not only limb ischemia and other areas. I would touch on a few points like has been mentioned by the hypertension and other things.
So from head to toe.
Yes,
So the one
it
is
can
head
be.
to toe.
Yeah,
Interventional cardiology is now available from head to toe.
right. It can go into carotids. It can go into the peripheral. Head to toe. All the vessels can be renal arteries and peripheral arteries. So one has to look for it. What is happening? And the people should be aware, or should at least physicians should explore this option before saying no. So this is one thing which various areas can be done. Another factor is the diabetes. Diabetes is a common factor with all these patients. So they have to give a strict control of their sugar. Whatever.
Are you talking about aggressive control? That means 5.5 to 6.5?
Yes.
You're talking about
It should
7%
be-
A1C.
It should be, ideally they say up to 7, but 6.5 is the ideal.
5 is what, yeah.
Yeah, that's the reasonable, because we have to be very careful when you're keeping very tight control. You can have more complications. So you have to look at the background of the people, whether they are educated enough
If
to
you talk
maintain.
about atorvastatin, you talk about 20, 40, 80 atorvastatin. What milligram?
I would say about 40.
40 milligram.
Yeah, it depends on the LDL level, what you're talking. If the LDL is about 70, which you like to maintain about 70.
What about TG and HDL? If the LDL is normal, are we in terms of vascular disease? We know that from cardiac point of view.
I think it will still holds true that we have to maintain a very reasonable, good control. Yes, you
Yeah, and I think there's data out there that shows that even people with normal LDLs
They can
benefit
have
from
statin.
statin therapy.
Yes, yes. And another thing what I was wanted to point out, like I would touch on an area like uterine artery embolization. It comes in a not exactly vascular, but it's a vascular related. Some patients, like after postpartum hemorrhage, excessive hemorrhage, can be blocked by surgery without surgery. Earlier surgeons, we have to take the help of a ligating the iliac arteries, and this is I had end up with a patient which was referred by a vascular surgeon saying we have to this is a primi gravida, and we don't want to do any surgical work. So that they came to me and I embolized the artery, and they were transfused already 18 units of the blood, and
Is
it
there any
improved.
age bar in vascular interventions?
No, I don't think it.
From
it's-
0 to 99?
It can go anywhere, because depending on the condition, because it's a very widespread condition, so that the age cannot be a bar as generally. It has to be dependent. Most of the peripheral diseases are related to age, like a distal peripheral artery disease, and as your age proceeds, it goes further up.
I think to just complement more, the oldest patient been operated for a complex vascular problem is Michael DeBakey
Right.
for his thoracic
Yeah,
aneurysm, which he did device. What I was going to say that the endovascular intervention has got no boundary. As he said, that you can go to the uterus, you can go to the veins, you can go to the AV malformations, or from aneurysm to carotid, all kind of things that can be done. But before we do anything of that kind, I think I would agree with that lifestyle management remains the cornerstone of anything that we do, before and after of any intervention. Now, this year, the prediction in India for diabetes is going to be 500 million people in India will have diabetes, 500 million people. Now, I think that is going to contribute to the vascular load of patients. 20% of diabetic patients will have vascular disease. And in future, we are trying to accumulate this number for the future.
Do you calculate in your country vascular age of a person?
So in you mean
Vascular
UK?
age, yes.
In UK?
Are we using that formula? Because we do it for vascular age
Yes.
by intima media thickness.
Yes, vascular. Yes, that's right. Yeah.
And we are finding it here that most of the Indians today are behaving a vascular age of 60 at the age of 40.
That's right.
Clinical age is 40 and the vascular age is 60.
Study in Bombay they did is the majority of the patients who died of MI were less of age less than 40.
Yes.
So you are developing.
Anything else? Any other point?
That's the major contribution that I could.
Okay. What I'm only going to add is that if you have my card and there is a formula of 80, and I'm just going to end up with that. I have this is for public. I have designed it. I said if you want to live without a lifestyle disorder up to the age of 80, then follow this formula of 80. And the formula of 80 says your lower blood pressure, your fasting sugar, the level of your LDL cholesterol, the abdominal circumference, and the pulse rate should be lower than 80. For that, walk 80 minutes a day. 80 minutes a week should be fast walking or jogging or voguing. That means in 1 minute you have 80 quick steps. Okay? Do 80 cycles of parasympathetic breathing. Eat less, not more than 80 grams of caloric food at a time.
Sorry, what is parasympathetic breathing?
Parasympathetic pranayam.
Sorry.
Slower and deeper breathing. Breathing with the rate
This
of
is
4
a
per
very
minute.
commonly practiced in
Breathing
India.
with the rate of 4 per minute. That's what parasympathetic breathing is. Then do not drink more than 80 ml of caloric liquid at a time. Sit in an atmosphere of less than 80 decibels of noise, because that causes hypertension. Okay? Then do not smoke. It will end up with 80,000 rupees bill. Do not take more than 80 ml or 2 large packs of alcohol in a day, and not more than 80 grams of alcohol in a week. Okay, everything is 80. Everything is 80. And the only thing I have added is do not do not take cereals. Do not take cereals. Do not eat.
80
You
milligram.
you described my mother to a T, and she died at 101 in 1 month.
And
It was well almost right up to the day.
80. We normally recommend in India do not eat refined carbohydrate 80 days in a year. And if you do that, you will not get metabolic syndrome, because that's an epidemic we are facing.
And if you do all this, you'll survive up to 80 years.
Without lifestyle disorders. Without lifestyle disorders.
Take 80 milligram of aspirin.
And for prevention, take 80 milligram of aspirin. And if statins are required, and if atorvastatin is required, again, it is 80 milligram. So it is all
Very nice.
80, and this is here.
Good, I saw that.
This is
Nicely done.
So,
Very good.
thank you, and we'll send you the copy of whatever we publish.